Okay. Says it's recording, so let's hope it is. All right. So the first few weeks, neural tube defects, those are your big concerns. Teaching we want to do with new moms is to avoid like hot baths and hot showers that can increase their chances of neural tube defects. And then of course, if there's a history in the family, they do genetic testing. We'll talk about that a little bit later for that. And then they give women, the chance to decide whether they want to continue the pregnancy or not. Some things are just, like with Down syndrome, the extra chromosome, and then some things are actually not going to be viable. The child may live 6 months to a year. So that's kind of a difficult conversation you may have to have with them on that. Usually we tell the baby sex, usually by 13 weeks, but they don't usually do the ultrasound for that until like 20 weeks, just so they can be extra sure. And then after about weeks 20 through 36, it's just kind of more of a refining and growing period. So pretty much everything is formed in that first to early second trimester. GTPT or GPTPAL. This one, the first P is para. So I don't know if they went over it this way with you guys. Usually if you just see GP together and the rest of it's not there, they're talking about gravida para. And I teach it this way because I don't want you to get confused and think they're talking about gravida preterm. So gravida, that's just the number of times that a woman has been pregnant. And then para is the number of deliveries that actually reached that 20 weeks. Whether the baby's alive or not when it's born, it still counts as a para. And even if it's twins, triplets, whatever, I don't know if there's 8 babies, it still only counts as one occurrence. So if you're giving a report or you're getting a report from labor and delivery and they say she's a G3P2, okay, so she's been pregnant 3 times, the only information that tells you is that there's 2 that have parachuted out of her body that reached 20 weeks, and that's all you know. You don't know anything else about them. T is obviously term, so that's 37 weeks or greater. Preterm, any infant delivered after 20 weeks, but before the completion of 36 weeks. Abortions, this does include miscarriages. So you just kind of have to be careful the way you word things with patients. There are a lot of patients that don't like the word abortion. And even though it is the technical terminology that we use, just be mindful of their wishes. They like to refer to it as a miscarriage. Living, that's the number of living children. So however many they have now. So usually we will only include that L if it's relevant. So if they're a G3P3, we just assume all babies are there. If they're a G3P3 but L2, then that's kind of a clue, is kind of be careful what you say around them because they have sustained a loss. Post-term, that's any infant that delivers after 42 weeks. And then viability that's the ability to live outside the uterus. Your book teaches 20 weeks. So we have to say that the age of viability is 20 weeks for this class. These are a lot of different changes that the moms go through in pregnancy. So just knowing that, as the baby grows, it has different demands on the body, cardiac, respiratory, especially involved. Just physically, the baby's size compresses organs. So if you think of that baby and they're stretching out, You know, it's pushing on ribs, it's pushing on the diaphragm, it's pushing on intestines. So, you know, those intestines get smashed, maybe they get constipated. Cardiac wise, that's a lot more demand on the heart because you have like 50% more blood and fluid in your body at that time. So your heart's used to just yours, and now it's got all this extra. So sometimes arrhythmias can be there, heart murmurs. That's why we listen to mom's hearts after they have the baby to make sure those murmurs are going away. And then just keeping an eye, you know, like on her swelling and everything, and making sure that it's not the heart being overloaded. But, you know, vaginal changes as well. They have a lot of discharge from all the extra estrogen influence that they have. Sometimes it's like a thick white secretion, and that's normal. So if they call in, that's just a normal discharge during pregnancy. Skin issues, some get that, like that little mask where they'll get really bad acne called acne vulgaris. Spider veins and varicose veins, those are things that happen as well. Stretch marks, some people get them, some people don't. A lot of it just depends on not just the stretching of skin, but dryness, hormones. It can be attributed to many different things. And then that linea nigra, or that dark line that they will get sometimes from the belly button down. And sometimes it has hair on it, and that's normal. So if they call in with that, that's some teaching that you can do with them. Normal weight gain is 20 to 30 pounds. And we want to be encouraging them to eat a balanced diet, especially one that with folic acid and iron. So just think of like leafy greens, lean meats, fruits, things like that. Caloric intake though, everyone is always, well, I'm eating for 2, so I just double my calories. Well, no, you want 300 calories a day more, and that's really about it. That's all the baby needs. You do have an increased need for drinking water and keeping hydrated though, especially during those early months when you have nausea. So if you think about a mom that has hyperemesis gravidarum, you know, the first thing they do when they go to the hospital is we put an IV in and we get fluids into them. So encouraging them, being proactive to drink that water is helpful for them. The duck waddling gait, that is something that as the baby grows, it puts weight demand on the front of the body. So it forces those shoulders to kind of go back, and you get that lumbosacral curve, and then we end up waddling near the end of the pregnancy. Making sure that they know about urinary frequency. That is a thing that can happen. I know a lot of women are surprised when they get a little bit closer to the end of the pregnancy and they're like, I actually wet my pants. I wasn't expecting that. But they can for many reasons. Sometimes the baby kicks and just smashes that bladder down and there's no control. And then sometimes it's just the tone, the muscle tone in the bladder. So we want to be sure that we're doing those urine dips when they come in for prenatal care, just making sure it's nothing like diabetes, gestational diabetes. Sometimes will increase urination as well. And that's just because the renal function has a lower threshold for sugar, and then they get into increased insulin resistance in the later months of pregnancy. Uterus, obviously, it's going to get bigger because that baby's in there growing. Braxton Hicks can start as early as 13 weeks. And then they start looking for signs of labor when they get into like that 36 to 40 week zone. Everybody's looking for mucus plugs and leaking fluids and things like that. So just making sure they're educated on what to expect. And then the endocrine system. Your endocrine system is working overtime right now. I mean, we've created a whole organ. So we have a placenta, that is only there during the time that the baby's there. So our body has to make way for that and accommodate for that. Thyroid changes can happen due to all the extra changes that are going on, and the pituitary enlarges in the 9th month, and that starts increasing those hormones needed for lactation to happen. So your prenatal care, making sure that they are getting care from the beginning of the pregnancy is very important. There's a lot of things that happen in those early months, a lot of testing and things that they need to be sure that they're getting. Knowing the presumptive, probable, and positive signs of pregnancy. Presumptive, people will say, well, my period's late and my breasts are sore and I have increased urination. So maybe I'm pregnant, and they go get a pregnancy test. So that's just presumptive. But there could be many reasons that those things could be happening. So that's why they are categorized as just presumptive. Probable, those things combined with a positive pregnancy test. You're starting to see some growth in the abdomen. Heger sign, or like the softening of the uterus, Chadwick sign, those things would be seen by your OB. The Goodall sign, which is softening of the cervical lip. And then ballottement is something, it's a little bit different. I don't know if you went over that in class, but ballottement is like, basically they tap on the cervix, and since the baby is floating in fluid, it floats the baby up, and then the baby floats back down and kind of like hits against the cervix. And so they can actually feel that something is in there. And then the Braxton Hicks contractions again, all probable signs. But really the only thing that we're going to say, yep, you are definitely pregnant, positively sure, is if we see it, if we hear it, and if it's felt by an examiner, and if we hear that heart rate. So those are really the only positive signs. We need to make sure that the patient knows their RH factor, whether they're positive or negative. We need to do a test for that, because we need to do the RhoGAM if they are negative at a certain week, which we'll discuss a little bit later. Negative titers. So we want Hep B to be negative. We want all of the STDs, obviously, to come back negative. Then we like to give the Tdap in pregnancy, but they don't always want it. So sometimes we try to encourage that after their pregnancy. And then rubella is another big one that we worry about. If their titer comes back negative, we don't want to give that one while they're pregnant because it's a live virus. But after the baby is born, before they go home, we do encourage them to get that MMR. And then no Boucher-Naegele's rule. So the last menstrual period, you go forward 3 months and then back 7 days. And then don't forget to adjust if you cross over the year. So this is the ABO incompatibility or ISO immunization, and that is the Rh negative factor. This usually affects the second pregnancy. So when we give them the RhoGAM, that is protecting the next child that they want to have. You will run into some people that do not want the RhoGAM shot afterwards. People who are getting their tubes tied, they're not planning on having any more children. Sometimes they will refuse it because it is a pretty decently sized shot. And then there are some religions that do not accept blood transfusions, and RhoGAM has blood components in it, so fractions of blood cells in it, and so sometimes they will not accept the RhoGAM shot. So making sure that we are really educating them as to the importance of this shot. Like if you're going to have more babies, you need to have this on board, or it could actually affect the next pregnancy detrimentally. So sometimes they will still refuse. And then after you have educated them and they still refuse, then that's just how it has to be. And you need to respect their wishes. And then be ready to advocate, because those doctors are going to want you to push. RhoGAM, though, is given at 28 weeks gestation. So they're far enough along that this, baby could come at any time. If they would have the baby before 20 weeks, then they would get it obviously after birth. It can be given anywhere up to 72 hours after birth. And that is given whether you have the baby or if you have an abortion or a miscarriage. With these ABO incompatibility issues, there's always a chance that jaundice can be much higher in these babies. So we start testing them earlier. I won't confuse you with all the orders on that, because it'll be different wherever you work if you decide to do this. But just know that jaundice is, they are at greater risk for high jaundice with these. These are the fetal well-being assessments. Non-stress test, it's self-explanatory. We don't put the mom under any stress at all. And we are just measuring baby's movements and heart rate accelerations. So a reactive test, that's considered normal. That's great. What that is the baby's moving so that fetal heartbeat accelerates to a certain level above the baseline. And it has to be twice or more for at least 10 seconds in a 20-minute window. If this does not happen, then we consider those non-reactive. The baby's not having fetal heart rate accelerations, so then we need to explore further why they are not having the accelerations. Sometimes that can be due to magnesium, so just keep that in mind for test questions and things. If a mom is receiving magnesium sulfate, so is the baby. That's a smooth muscle relaxer. So sometimes their fetal heart rate tracing won't differ very much. There's a BPP, that's the biophysical profile, monitors fetal breathing, body movements, the fetal tone, so whether they are stretching their arms out and pulling them in. It measures the amniotic fluid volume, looks for the pockets of fluid around the fetus. And then there's the reactive fetal heart rate with activity. So that is basically a reactive non-stress test. So with the BPP, for every positive finding, normal finding, they get a score of 2 and they get a 0 if it's an abnormal finding. Maximum score of 10. So we would like to see score of 8 to 10. If it's lower than that, we are going to explore that further. This is the anatomy of a contraction. This is kind of what it looks like on the monitor. That's the bottom row. So when you guys went to clinical and you see the 2 rows, the top row is the fetal heart rate and the bottom row is the contraction. So you have where it's building on that front end, and then it peaks there in the middle, and then it starts to decrease and it does its downward movement. And then you have frequency. So that is the time that it takes at the beginning of a contraction to the beginning of the next contraction. And that's how we measure how many minutes apart they are. Duration, that's the time from the beginning of a contraction until the end of the same contraction. So how long just that one lasted. And then the interval, that's the amount of time that the uterus gets to relax between the contractions. So what happens during the interval is that blood flow from the mother decreases during the contractions and then resumes during each interval. So that is allowing for blood flow to return to mom and to baby. And then the placenta refills with that freshly oxygenated blood for the baby, and it removes the fetal waste products. So what happens if we turn the Pitocin up too high, we get contractions called piggyback contractions, or they're right on top of each other. And that does not allow for a decent sized interval. The problem with this is mom can't get her breathing under control because she's not getting enough oxygen. She's not getting enough time to relax to be able to breathe, which means baby's not getting oxygen, because whatever's happening to mom is happening to baby. So that's why we need to be careful, and we really monitor those contractions to make sure we want them close together, but we don't want them too close together that it starts to affect blood perfusion. Assessing the fetal heart rate baseline, that's got to be assessed for a minimum of 2 minutes in any 10-minute segment, or the baseline for that time period is indeterminate. So if the baby's moving all over the place and we can't get them to just like hang out in a certain area, that's a lot of variability. So this case, sometimes we'll look back on the strip and see where we found an area where this was likely. And we've got that little strip that we need. And so we use that to determine the baseline for time being, and then just kind of assess again what's going on, why the baby is not holding still for very long or staying stable for very long. It could be that mom's moving around, or it could even be that the Toco machine is getting moved around. So again, in that situation, if we can't capture a 10-minute window and get a baseline, then we just need to assess what's going on. The normal baseline is anywhere between 110 to 160 beats per minute. Tachycardia is if it is sustained greater than 160. If they go up over 160 and they come right back down, we don't necessarily call them tachycardic. And then bradycardia, that is baseline less than 110. And again, there are times where they're going to go below that 110, and we just keep an eye on that. So with those things in mind, the D cells here on this strip, it's kind of like a little hodgepodge of different ones. That first one there is just a little bit late. As you see, like it increases, and then we have the couple of peaks, and then it's actually coming down right after that D cell drops. So the green line, that's the heart rate, and these pink lines at the bottom, those are the contractions. When they're spiked up like that, that is usually indicative of the mom is pushing at that time. The second contraction, it's right on top. So we have that green D cell happening like right about the same time as the pink is happening, and that's perfect. That's what we want to see. The next one is early, and early is good. So we come right up here at the peak, and we've got the D cell sitting right on top of that first peak, and it remains throughout the pushing, and then it releases at the same time. So those are good as well. When they're early like that, that's just meaning that the head is being compressed in a normal fashion to move the baby down towards delivery. The one on the end, the fourth one, is a little bit, it's kind of on top, but then it lasts a little bit longer than we would want it to. So we watch those. That one's not a very bad one, but we still will watch this. And if they have too many of those, then we are going to be calling the doctor. So these are variable decels. So in that Beal-Chop-Mine, this is the first one. Variable decels are just, they're like tornadoes. They drop anywhere they want to drop. They are no relation to the contraction whatsoever. And so usually with these variable decels, it's some type of cord compression. So if you see too many of these, especially if they're very deep like these are, you're going to try to find out what's going on there. And obviously you would call the doctor on that. Too many of those deep variable decels, and it will usually end up in a C-section. These are late decels. Those are pretty plain and clear. You can see mom's contraction happening just like it should. And then that decel is coming after the peak of the contraction when the contraction is decreasing. So what that's telling you is that is placental insufficiency. That can mean a lot of things, but for some reason, oxygenation or blood flow is not happening like it should. So then you need to explore those, and too many of the late decels, unfortunately, will usually end up in a C-section as well. A lot of times we do many things first, like we'll try to turn them to their left side, we'll give oxygen, try to get them to look better. Sometimes we can kind of pull them out of them. These are the prolonged decels. These are very ugly. We don't like these. These will make nurses get up and run. So with a prolonged decel, you have to think about all those little pink boxes that the baby is not getting oxygen, especially that second one. If you look at that one, those hard lines are a minute, and we've got this baby down almost a full minute and a half. That's almost a full cycle of CPR. So that's like walking up on somebody who's completely unresponsive and then standing there for a minute and a half deciding what should we do. So if you think about it in those terms, those prolonged decels are very, very nasty. And usually 2 of those buys them a trip to the OR, and it's a C-section. And those are category 2 strips. This is the minimal variability that I was talking about, where there's not a whole lot of change from baseline. This is a magnesium sulfate affected baby in this one. So you can see mom's contractions going on down here, and baby's just chill. It's not reacting to those contractions at all. Not impressed. And so for a while, this strip, we may let it go for 30 minutes because babies can take naps. And during those naps, they're just kind of floating in there. And their heart rate can look like that. But after about 30 minutes max, we're like, okay, what's going on? And so sometimes you would hear at the nurse's station, oh, that's a magged out baby. So what they're referring to is the mom is on magnesium sulfate. And some of these moms have been on magnesium sulfate for several days because they are trying to stop early labor. So this baby is just had it. We've had magnesium sulfate for days, and their body is showing it. So they will only let this go on for so long, though, until pushing is not going to be effective, and baby is, not showing a whole lot of variation from baseline. So how long do we really want to let that go on? So a lot of times they will go ahead and do a C-section on these moms as well. So here's that lovely Beal-Chop-Mine that you guys probably got really sick of hearing about in class. But at the top of this slide, we have the Beal variable decels, early accelerations, and late, and what causes them. There's the cord compression, head compression, oxygenation, and placental insufficiency, and then how we fix it. So if we've got variable decels going on, we said the most likely cord compression, we try to move them up. Because sometimes babies can get that cord wrapped around a wrist or a hand, they may be squeezing it. So we try some different positions with mom and try to move that baby around and off the cord. Early decels, that's head compression. So the I is just identify labor progress, because the greater, the deeper those decels get, as long as they're early, that is most likely the head moving further down, getting closer to being delivered. So we just want to be sure that we're checking mom and making sure that we catch it early enough so that the doctor has time to get there. Accelerations, that just means increased oxygenation for the babies. That's normal. You don't have to intervene for that. Late decels, again, we talked about that, placental insufficiency. This can be an emergency because for some reason or another, blood flow is not getting through to the baby. So there's many different acronyms that you can use for what we do in the late decel, I guess, treatment. So we want to move mom to left side because we try to do the least invasive first. We may need to increase fluids. We may need to give oxygen, notify the provider, obviously, and then stop the Pitocin. You can stop the Pitocin without an order if the baby's heart rate is dropping below 110. And then always in this situation, especially the prolonged late decels, check for a prolapsed cord. So many times you can't see them because they're still way far up. And sometimes you will go to look and the cord will actually be hanging out of the vagina. So what you need to do for this, if you are the primary nurse, you are going to most likely jump on the bed and place 2 fingers in the vagina so that you press the presenting part off the cord. And you will stay like that. You will ride down the hallway with your butt in the air to the OR until they can perform a C-section for that baby. While you're doing that, someone needs to be putting the bed in Trendelenburg position. And that is basically so that gravity can help float the baby off the cord and allow some oxygenation to get through that way. And it's a little bit easier to keep your fingers there holding that part back. Leopold maneuvers. This is kind of how they try to check placement of the baby, make sure the baby's head's down. Sometimes they can try to guess the weight of the baby. Some doctors are very accurate with these measurements, and then I've seen some be way off. Stages of labor. Stage 1, that is the stage during dilation. Often the longest, most agonizing stage. So that begins with the onset of regular contractions and then ends when the mom is complete. And stage 2 begins when we are pushing the baby out. Stage 3 is when the placenta is coming out. And then stage 4 is recovery. The rupture of membranes, you will see those in notes, ROM, SROM, PROM, PPROM. If you decide to do this for a living, it will become like another language to you. Spontaneous rupture of membranes is SROM. Artificial rupture of membranes is AROM. Premature rupture of membranes is PROM. And then rupture of membranes in a term 37 weeks or greater of pregnancy before the onset of contractions. PPROMs is before 37 weeks. So that's a preterm, pre-rupture of membranes. Most common cause for the PPROMs is infection. And then the gush of fluid, especially if the mom has excess fluid or polyhydramnios, could cause a prolapsed cord. So just make sure that you're on top of that and making sure that that cord, watching those fetal heart tones in response to the contractions. Pain control during labor. A lot of people opt for the narcotics. So the epidural, things like that. There is Stadol and Nubane available. They don't really take away a lot of the pain. They just kind of twilight you, kind of like Burr said. Opioid antagonists, so Narcan, we always want to keep that on hand, just in case that they don't tolerate it well or they get a little too much. And then our analgesic potentiators, so Phenergan, sometimes that can enhance the effects of these drugs, and benzos as well can do that. So prolapsed umbilical cord, this is when the cord slips down into the pelvis after the membranes have ruptured. So the different terminologies for those, the complete, that's when it's actually visible. Scariest thing you'll ever see. Palpated, you can't see it, but you can feel it. So you may feel like a pulsing strip going across as the cervix is dilated. And then the occult, which is hidden and can't be felt. Medical treatment, we talked about that, pushing the presenting part upward and then using the Trendelenburg position to float that baby off the cord. Types of anesthesia in labor. Some of these we don't use a whole lot. Local infiltration, pain balls, lidocaine patches, IM injections. We don't do those a lot during labor. Sometimes afterwards or for C-sections, sometimes they'll use a pain ball. A pudendal block, that's a local nerve block. So if we have to do some repairs after that, we will give that. The epidural, that is the most popular. It is a PCA, which is patient-controlled analgesia. And it's also continuous with a catheter placed in the spine, in the epidural space. So they're getting a little bit all the time. And then during times of greater pain, they can push the button to give themselves a little bit extra. And that is dosed. It's a metered dose. So it can lock itself out so they can't overdo. There is the spinal block. That's a one-time injection into the epidural space, into the cerebrospinal fluid, and it affects a larger portion of the body. So like from the T6 all the way down to the feet. And so that's usually what we will use for C-sections. And then there's general anesthesia. A lot of times there are moms who cannot tolerate certain medications, or in the case of an emergency, sometimes you'll hear them call it dropping the mom. That's basically what we do. Like, we need to get baby out in 2 minutes, so we just have to put her under quickly. Most common side effects with these things are hypotension and urinary retention. We give IV boluses with these to try to prevent that hypotension. Always be assessing the bladder. So usually straight cathing, especially, they can't get up and go to the bathroom. So you kind of have to remember, oh, it's been a couple hours, let's drain that bladder. And then there's always the risk for malignant hyperthermia with general anesthesia. And that is something that's usually inherited. It's like a family trait. So we usually will ask that question on admission if they know of any family members that have had that. Non-pharmacological pain management, breathing techniques. There are different methods out there and different classes that you teach these. There's the Bradley method, which encourages relaxation breathing, and it is for tolerating those strong contractions. So having them inhale very slowly and deeply through the nose and exhaling through the mouth. Sometimes this is used together with some of these other things that we'll talk about. The faster paced breathing, or like you usually see in the movies, that is breathing for short burst intense pain. So usually when birth is happening, they will be using that method. We don't want to use that method too much because that faster paced breathing can lead to respiratory acidosis. Aromatherapy, this is becoming more and more popular. I'm seeing like the reed diffusers or like essential oils being, put in those little machines that make the steam. They've been using those quite a lot. Sound therapy. So some people like to listen to their favorite music. I walked into one room and they're playing the Bee Gees and I'm like, okay, that's, whatever, you do you. Sometimes ocean sounds, nature sounds, whatever they like. Sacral counter pressure. This is something that when the mom is sitting like on the birthing ball or in the bed, you can actually take a fist and you put pressure on that sacral area, and that can help relieve some of that pain. Guided imagery, that kind of goes along a lot of times with the sound therapy and the Bradley method of breathing. And that is talking them through those contractions. A lot of people, like if you tell them to pick their favorite place, so you have to get real creative sometimes with them. Usually it's a beach, I'm by the ocean, they're listening to their ocean sounds and they're doing their breathing. And so you're talking them through it, like the contractions are waves and the wave is building and it's washing over them. And okay, now we're going back and it's down. And that really works well with a lot of moms. Local hot and cold therapy, so cold packs, hot packs, however mom's feeling. Sometimes cold rags on the head can actually do a lot for moms. TENS units, we don't use these a whole lot, but I have seen a couple of them. I used to be a doula in the 90s. I saw them a little bit more back then. I don't really see them a whole lot now. But the transcutaneous electrical nerve stimulation. So it's just like a little mild electrical current that just kind of interrupts the pain signals to the brain and kind of helps a little bit. And then obviously position changes. So whether, it's pillow placement, birthing ball, left side if it is the best side, of course, if we can. The peanut ball, sometimes that likes to go between mom's knees there and just kind of widens those hips a little bit for them. Water, some people like to sit in the water. They want to birth in it, but they want to sit in it for a little while. It does help the contractions. And then sometimes ambulation. Some moms, they like to walk around the room. So it's just finding out what fits your patient best. Induction of labor. Labor is induced if continuing the pregnancy is hazardous. We try not to induce just because the mom wants it to happen. Reasons, gestational hypertension is probably the number one reason that we induce moms. Ruptured membranes, obviously we're going to go ahead and get that labor started, because if they are ruptured for more than 18 to 24 hours, we're increasing that risk for infection. If they're post dates, sometimes we will go ahead and get that ball rolling, especially if there's a little bit of leaking water and it's dark green. So baby has passed stool inside mom, or that first poop, that meconium, that can be an infection risk as well. So we'll go ahead and start that process. If we know that there's an infection in the uterus, so chorioamnionitis, we will go ahead, we'll be running IV antibiotics during that time that she's laboring. And then baby will need treatment afterwards with IV antibiotics. Medical problems in the woman that worsen during prolonged pregnancy, or any kind of incompatibility between fetal and maternal blood types. That's probably going to happen pretty quickly. We're going to get that baby out. Placental insufficiency, obviously, and then fetal death. We would go ahead and once it is past a certain date, they do actually have to birth that baby. So the contraindications for that, obviously placenta previa. So if the placenta is in the way, we're going to go ahead and do a C-section. Umbilical cord prolapse, we're not going to try to push through that. That would not be smart. Abnormal fetal presentation. So if you go to check mom and you feel a hand grab your finger, that's probably not going to happen that way. So that will probably be a C-section. High station. So that station is where the head is in relation to the bottom of the pelvis and the cervix. So if that baby is just not coming down, we got to figure out why the baby is not coming down. If the baby just continues to not engage, then chances are that the shoulders are probably too big or they're not positioned correctly. And if you force it through, you could end up with a shoulder dystocia. Active herpes infections, we do not, if there are any open lesions whatsoever, we do not bring the baby through there. That is very bad for the baby, can cause blindness, death, lots of other things. Abnormal size or structure of the mother's pelvis. So gynecoid pelvis, that's normal. That's not a contraindication, but sometimes babies are just too big. Previous classic vertical cesarean incisions. Some doctors are now beginning to allow these. They are very risky. They usually will deliver them in the OR in the case a rupture happens. Horizontal incisions are okay. Those are done lower and less risk for abruption. Pregnancy-induced hypertension, when you're caring for a mom that has hypertension, we just want to make sure we're promoting bed rest and quiet, making sure they're getting plenty of protein. Antihypertensive medications sometimes have to be given. A lot of times they're on magnesium. We talked about that. And then make sure we're evaluating those physical parameters. So the blood pressure, their output, respirations, and their reflexes. If they're on magnesium, they have to be having the deep tendon reflex assessments. So this is the board that I always write for my class for gestational hypertension or pregnancy-induced hypertension, GHPIH. The NCLEX likes to use these acronyms interchangeably. They both mean the same thing. Basically, hypertension is there because there's a baby. So that blood pressure, our parameters that we consider for hypertension, anything over 140, over 90, that's considered like a mild range. 160 to 110, we're getting into the more severe range. 160 over 110 is usually our threshold, and we start looking at hypertensive crisis medications. The thing with hypertension, if you have a mom and you know that they have hypertension, you want to be on top of it from the very beginning, because if you don't, it can really snowball quickly. And a lot of moms come in, they already have the hypertension, they already have pre-E, you know that. So you need to make sure that those blood pressures are staying down. So frequent vital signs, getting that hypertension protocol started early rather than waiting until other symptoms show up. And the hypertension protocol, it will be different wherever you go, but just know that it involves IV hypertensive medications. So you are going to be giving like labetalol and nifedipine and things like that to bring that pressure down. Pre-E happens when you have these blood pressures, and then there's protein in the urine, and there's edema. So they have an increasing amount of edema. Those are the three signs that we look for to diagnose pre-E. Depending on where you work, it can be just a urine dip. If they're +1 on that, that is considered proteinuria. And sometimes it can just be 300 milligrams per deciliter on a 24-hour urine. So that is dependent on, again, the doctor's order. They become eclamptic when they have all these things plus seizures. So seizures is a whole another level, and seizures are telling you that you are not getting that blood pressure under control well enough or fast enough. And when the seizures start happening, this widespread vasospasm that's being caused by high blood pressure, it's affecting all of your major organs and obviously the baby. because what's happening to mom's happening to baby. So the seizing is happening in the brain. The seizure is happening in the renal system, the ureters. It's happening in the liver, in the hepatic regions. And it's happening to all of the blood vessels in the placenta that's carrying the oxygen and blood to the baby. So when we're talking about placental insufficiency, that's what this is. So we are cutting off blood and oxygen to the baby. So things you start seeing are seizures. These could be caused from swelling in the brain, or it could be caused from microhemorrhages in the brain. Because once the blood pressure is sustained at such a high level, these start to pop. These little vessels start to pop in the brain, and especially in the liver. You get these little microhemorrhages. As that goes on, the longer the seizures happen and all this vasospasming is happening, and we're not getting that down, the antihypertensives are to bring the blood pressure down, but then we add the magnesium sulfate, and that is for the seizures. That is not for blood pressure. They will try to trick you on tests with test questions. They will, talk about a mom having high blood pressure. What should we give? And magnesium sulfate, they're always going to throw that in there as an answer. That is an anti-seizure medication, not a antihypertensive. So we give a 4-gram loading dose, 4 to 6 grams loading dose of that, and 1 to 2 maintenance dose. And then we are making sure that we are doing those deep tendon reflex assessments, because the magnesium, some people are very susceptible to medications, pain medications and things like that. This is a smooth muscle relaxer. So we can relax too much and then we have a problem. So we have to make sure that we have the antidote for that very, handy. So anything greater than 8, if you do a magnesium toxicity level and it's greater than 8, you are looking at magnesium toxicity, and you want calcium gluconate to counteract that. So all of these things, if they're not being controlled, HELLP syndrome can be standalone, but it can also be a process of just poorly controlled hypertension. It can also occur without hypertension, the standalone, and it's idiopathic, and we don't really know why some people have it. But what it is, the HELLP stands for is hemolysis, which again is idiopathic. The elevated liver enzymes, so your ALT and your AST, you are looking at those. And then low platelets, so anything less than 100,000. And this is a very bad combination, because when all this is happening, hemolysis, break that down. Hemo is your blood and lysis. So they're damaged, right? And then you have low platelets. So anywhere there's a hole in the body, there can be blood oozing out of that. So when you know that someone has HELLP syndrome, you try not to poke them as much as you can. With those very low platelets like that, we are not going to want to give an epidural, obviously, because that's a catheter keeping that open. And when you get to DIC, which is decimated intravascular coagulation, that is part of that whole coagulation cascade thing. When you cut yourself, all the things rush to that area to stop the bleeding, right? All of our white blood cells, all that goes and tries to stop that and scab it over. Well, once it is trying to scab those places over so much, it finally wears out. And so then you don't have those white blood cells and all those clotting factors to go there and help that. So it's just basically like free bleeding and nothing stops it. So from that point, our only lines of defense are fresh frozen plasma. We have to put that plasma back, right? Because that has all of our clotting factors in it. or mass transfusion if it gets to the point where they are bleeding out very quickly. And mass transfusion is actually done with a machine. I don't know if anyone works emergency or has seen it. It's kind of like a T-shaped machine, and it's got very big tubing that you just can't mess up. I mean, it's like purple triangles and yellow circles, and you match them together so that you can do it when you are in a high panic situation, which you will be. And one side is the blood from blood bank. And then the other side is normal saline, because that's the only thing we run with blood, right? And so as one is going in, the other one is waiting. And so as soon as that bag finishes, and it finishes in like 2 minutes, then the other one starts infusing. And it goes that fast, and you're just pulling and putting bags in and pulling them out, and just basically just throwing them in a biohazard box at that point. So it's a very scary situation. Also with this, what can happen, and we're going to look at a picture here in just a little bit, but there is a thing called a subcapsular hematoma, and that forms in the hepatic region, right by the portal vein of the liver. And once that breaks, it's like a 75% mortality rate on that. So that's why it is super important to get that blood pressure under control as early as possible. So this is what the liver looks like. So those microangiopathic hemorrhages, that is the picture on the bottom left. And it looks like, and I always try to explain this to people, it looks like those little bang pops that used to play with when you were kids, like you would throw them on the sidewalk and they make those little black burnt marks. That's what the liver looks like. And that is from all those blood vessels popping. The pictures on the right, the bottom one, that's showing you where that subcapsular hematoma is forming. And then the picture above that is when it ruptures. So preeclampsia, there's that classic triad, your proteinuria. Again, the rising blood pressure, we got to get that under control. And then the sudden weight gain edema, their feet and legs usually will swell up really quickly. Severe preeclampsia, also known as HELLP syndrome. Again, they can, not pass go and not collect $200 and just go straight to HELLP syndrome. So. That's some more information on HELLP syndrome. So teaching newly pregnant women what to report, because often this can start early in pregnancy. So the sooner we get it under control, the better. If they're having any visual disturbances or headaches, flashes of light, spots before the eyes, all these are early signs. GI symptoms, nausea, which, that can be pretty common, but we're looking for that epigastric pain. Worsening edema in the face and fingers, and then always that noticeable drop in the output. These are just some other things that can happen in pregnancy. Placenta previa, that's the painless bleeding. Abruptio placenta, that is the painful, very tender abdomen, rigid usually. We'll talk about this hydatiform mole here in a minute. We're going to get into that one. Hypertensive disorders, hyperemesis gravidarum. And then the incompetent cervix is probably one of the biggest things that we see. We do what's called a cerclage, or they used to call it a purse string procedure. And that's basically where they have to stitch the cervix closed to maintain the pregnancy. And that's a picture of the cerclage or the purse stitch. Again, treatments used for threatened abortions or miscarriage. or incompetent cervix. So for whatever reason, labor's happening too soon, baby's healthy, but there is a risk of very early birth. So we try to prevent that. Vena cava syndrome in moms, if they're on their back too long. The supine position, the heavier they get, all the weight of baby and weight of the uterus, it compresses that inferior vena cava, and then it reduces the amount of blood that gets returned to the heart. So we do this, fix this by turning them preferably to the left side. Seems to be the answer for everything in OB, but it will relieve the pressure. If the woman has to remain flat for any reason, try to support her lower back with a small towel or under one hip, like displace one hip so the baby kind of goes off to one side. This is that hydatidiform mole. This is a lot of times people will say, oh, they found this like, I guess I ate my twin or something. I was supposed to be a twin and this thing was inside me. We hear stories like that all the time. It's actually a tumor, and it is treated with chemotherapy. And it takes about, it's 100% curable, and they can still have more children, but they ask you to wait about a year after having the chemotherapy. So, but it can be cured. A lot of people get real scared when they find out that it's a tumor actually. So, but it is curable. These are some abnormals that we're going to go through vasa previa. So vasa previa, you've got the umbilical cord coming from baby that is supposed to insert directly into the placenta. And it's covered in that Wharton's jelly. That's the gooey stuff around the two arteries and vein. The vasa previa happens when the Wharton's jelly does not cover all of the vessels, and you see how it has slipped down below that baby's head. So the problem here is if we try to push that baby through there and it obviously breaks those vessels, then baby can bleed out very quickly. So we need to make sure that we know where those, if this is identified early in pregnancy, that we know where they are at before we try to deliver this baby vaginally. Velamentous insertion, a normal placenta, the umbilical cord, if you're looking an aerial view at the placenta in a bucket after it comes out, that umbilical cord inserts in the center. Usually that's normal. So if it is inserting on a side of it, that would be a velamentous insertion. And problems with that can be reduced growth for the fetus, because I mean that nutrition can be impeded. It's taking longer to get baby because it's on one side of the uterus or of the placenta rather than being in the middle where it can be dispersed evenly. This is the abruptio placentae. So this is, again, you get that abdominal rigidity. It could be very bad pain in the back or in the stomach. Some people have like a retroverted uterus and they get that more pain in the back. So just pay attention to that. Vaginal bleeding, although it's not always present because sometimes it could be like an occulta abruptio. So there on the right side are some pictures of that. That's an actual placenta that erupted up in that right-hand upper picture. The normal placenta on the bottom there, bottom left, showing you how it should look. The middle one is an obvious hemorrhage, and you will probably see bleeding with that one. And then the concealed hemorrhage, there's a pocket there, and it looks like where baby's kind of pressing up against that one side. It's not allowing it to leak out, so we can't actually see that. This is a big thing that is common with mothers who use cocaine. Placenta previa, so that is the different degrees where the placenta can be lying. Obviously, we like it to be up by the fundus or the top of the uterus, but for some reasons or another, it doesn't always happen that way. So that first one there, the very mild one, a lot of times doctors, some of the more progressive doctors will go ahead and attempt a vaginal delivery with one like that's just marginal like that. And some doctors won't even touch that. Some doctors are like, nope, we're just doing a C-section. So things to consider there. Further over, like type 2, type 3, type 4, obviously, those are going to be, sometimes the type 2s, doctors are fairly certain they can kind of push that out of the way. And some will actually deliver with those, but type 3 and type 4 are always going to be a C-section. So these are types of accreta. Accreta, increta, and percreta are just worsening forms of accreta. So the normal placental attachment, several minutes after the baby's born, it normally detaches itself and then it comes out. With accreta, this doesn't happen. So we have to go in and get it pretty much. And if it's just a normal accreta that is just through like the endometrium layer, sometimes they can save the uterus and get that out. With increta, it is much more invasive and goes all the way down there through the different layers. So the a lot of times we need to remove the uterus with increta and percreta. Percreta is all the way through the uterus and can actually even affect surrounding organs. So they have to kind of measure that degree and then decide what they're going to do from there. So this is presentation of the baby through the pelvis. Obviously, we really like when baby is in a correct position. It makes things a whole lot easier. So the anterior or like face, so if they're the occipital, they measure it by the occipital bone. If the occipital bone is anterior, which means they are face down when they come out, that's the preferred method of birth. That's it. The pelvis is shaped better and that the head can pass through there easier. If they are face up, it makes it a little more difficult to get down through there, causes a lot of facial bruising. So that is something you would look for on assessment. And sometimes they even have like a scrape from like the tip of their nose all the way up to their forehead. This is a little about Pitocin. So making sure that we are monitoring moms while they're on their pulse changes, making sure we don't get the hypertonic state where our contractions get right on top of each other. Side effects of Pitocin. So we're taking those blood pressures, intake and output, neck contractions, oxygen can decrease, arrhythmias, cardiac arrhythmias, irregularities in the fetal heart rate. So making sure you're watching your strips, and then nausea, vomiting. Mechanisms of labor, there's plenty of sayings for these. Every darn fool in Egypt eats raw eggs. So you have your engagement. So that's when that head's getting down there. And then they descend, flexion, and then they kind of internally rotate as they're coming out. And then they extend through their external rotation, and then finally baby is out. It's their fetal station. I believe your book goes from -5 to +5. I guess they have just different ways of measuring that. I think a +5, the baby would be all the way out and down the block, but Fetal station, mostly we measure it from -3 to +3. Negative, the way I remembered this, negative is negative for go right now. So we are at -1, -2, -3 station. That baby's nowhere near delivery. 0 is where we will really want to note that it's a very important place to get. So once they're at 0, it's all positive. 0 is where your ischial spines come in. That's the narrowest part of the uterus. So if baby's head can get down past that 0, then we are good. Usually there are no more defects. Now they can twist in there, shoulder dystocias can happen, but for the most part, once they get past those ischial spines, then we know baby can come out. +1, +2, +3, that's positive. We are a go for delivery. So the bigger the number gets, the closer they are to being delivered. Uterine relaxants or tocolytics. So we give these when we're in danger, we're in early labor, and we're in danger of having that baby early. So sometimes I'll give some NSAIDs. Nifedipine can sometimes relax that. Magnesium sulfate is usually our one of choice though. And we're using that more and more. Sometimes they use the terbutaline, but normally we will try to keep the mom on the floor, like up on the maternity floor with magnesium going is the safest thing that we've seen. Risk factors for preterm labor. We have modifiable and non-modifiable. So things we can change, things we can't change. So we can stop smoking. We can make sure that we drink plenty of water. We can get prenatal care. We can stop substance abuse or get treatment. And then of course, risky behaviors. Non-modifiable: age, infection, pre-E, and any kind of premature rupture of membranes, and multiple gestations. Treatment for preterm labor, tocolytics, we try to stop those contractions. Lytic is anything that is going to stop something. Magnesium sulfate, again, drug of choice. Make sure we have our calcium gluconate on hand in case of toxicity. Make sure we are monitoring respiratory rates, lung sounds, looking for signs of fluid overload, because if you think about this, everything in your body is smooth muscle and everything is relaxed by this smooth muscle relaxer. So I heard one lady describe her patient as a boneless chicken breast, and that has stuck with me forever, and I thought it was hilarious. But that's kind of how they are, you know, as this magnesium goes through, it's almost like they don't have any bones. So they just get real lax. So be careful taking them to the bathroom, make sure that they've got all of their fall risk care plans and things in place. Everything else relaxes too. So their intestinal muscles. So make sure we're listening for bowel sounds, things like that. Some ladies will get diarrhea too. So you just have to watch for those things. If you suspect magnesium toxicity, if their DTRs or deep tendon reflexes, you know, if they're 0, they're not reacting, they're not answering you, obviously stop that infusion immediately and notify the physician. Fetal lung maturity, your LS ratio should be 2 to 1. Be prepared to give steroids to boost that lung maturity. 24 to 34 week gestations, pregnancies, watch those blood sugars with mom, especially if she's gestational diabetic. Betamethasone or Celestone is the trade name for that. We are administering that IM in 2 doses, 24 hours apart. So they will really run that magnesium to keep that mom pregnant, at least for those 2 doses, so we can boost baby's lung maturity. Postpartum fundal assessment. So they come down to you after they've had this baby and you're doing the assessment. So we want to feel for the top of that uterus. So before they delivered, it's somewhere up by the xiphoid process. And then after delivery, it comes back down to about the belly button area. So it can be slightly above, it can be right on it, or it could be slightly below. And then each day we assess that they are in the hospital, we assess that, make sure that it is going down properly. And then make sure you're educating your patients before they go home on how to do their own fundal massage, and kind of feel for that. If their bleeding gets very heavy, have them feel for that, the top of that fundus, and see if it's shrunk down like it should. Subinvolution is the ceasing of the uterus to return to its normal size. And so the uterus gets irritated and starts to bleed in response to that. So we're going to teach our patients, obviously, signs and symptoms of hemorrhage. Those are, if they're feeling for that fundus and they don't feel it, all they feel is squishy. That's a boggy uterus. So teach them how to do their own fundal massage, and they should feel that boggy uterus firm up under their massaging hand. If they're passing clots larger than a golf ball, or if it doesn't quite all look like blood, there could be pieces of tissue or retained placenta that comes out. If they're soaking a pad in 1 hour or less, any large gushes of blood, or a deviated bladder, teach your patient how to massage their own fundus and instruct them to empty the bladder every 2 hours. Sometimes they may not feel like they have to go, but they should at least try. All of that urine in the bladder, increases that in size, and then it will displace the uterus off to a side, which causes increased bleeding. So the Bubble E assessment, that's the postpartum assessment that you're going to do on moms when they come down. We're going to assess the breasts to make sure that nipples are in good shape to be able to feed the baby, that they are everted. If they are flat or inverted, we need to make sure that we are contacting lactation. If you're lucky enough to work day shift, if you work night shift like I did, you kind of have to figure that one out on your own. So using nipple shields or breast shells to help pull those nipples out is sometimes needed. Uterus, so we're measuring the fundal height and tone of the uterus. Bowel, if they have bowel sounds, we want to ask them if they have been able to pass gas yet. They don't always poop before they leave the hospital, and that's okay. They don't have to. But if they do, we want to make sure that we're asking about size, color, things like that, and charting them. Don't forget to document it. If you don't document it, it didn't happen. Bladder, assessing for the location, again, see if it's midline or if it's off center. Sensation, making sure that they can feel the need to urinate. Sometimes with epidurals, we have a Foley catheter in for a while, and it's amazing how fast the brain can reroute and delegate activities. So we know that urination starts in the brain, right? It sends the signals get sent to the brain, and the brain says, yep, you got to empty that. Well, when you put the catheter in, that totally interrupts that entire process. And so the brain's like, oh, don't got to worry about that right now. I'm going to go on to other things. And so then when we pull that catheter out, sometimes the brain's like, whoa, hold up, what's going on now? I thought somebody else was taking care of this. So sometimes it takes a little while for them to get that sensation back. So just make sure that you're checking on them, that they void after giving birth we'll give them about 6 hours. At that point, we're going to drain that bladder for them. So we may have to straight cat them a couple of times until the brain catches back up and realizes that it is now responsible for emptying the bladder again. Make sure that if there is a catheter placed, that we are doing pericare they can't really get down there to do that. So we need to make sure they are staying clean and free of infection. The lochia, that's the bleeding after birth. So we're going to measure the amount, the color, the odor, whether there's any clots, how large the clots are, and how frequent. Episiotomy or skin tears. So we just want to note the skin condition, the stitches, if they have stitches, any redness around that, any swelling, anything like that. And then we're assessing emotions because baby blues, they can happen 2 to 4 days. They can still be in the hospital when this happens. So we need to make sure that we're encouraging moms, letting them know that the baby blues are normal, and then letting them know the differences between baby blues, postpartum depression, and then postpartum psychosis. This is your laceration assessment. So RETA is what we're assessing for, which is redness, edema, ecchymosis, discharge, drainage, and approximation. The different degrees of tearing. First degree is, tiny, sometimes it needs a stitch or two, sometimes it can heal on its own. That just kind of depends on where it's at and what the doctor's preferences are. Second degree, that's slightly larger tear. It involves some of the muscular layer in and around the vagina and the perineum. This is the most common tear that we see. Third degree tears, that extends from the vagina all the way through the perineal area and involving skin and muscle layers, including like the very beginning of the anal sphincter muscles. Those are nasty. The fourth degree though is terrible. So that tear extends from the vagina through the perineum and the anal sphincter and out up into the rectum. Actually, so it is, unfortunately, it's the least common tear, but it is a lot to come back from. Postpartum complications. So mastitis, a lot of times they will develop this after they go home. So you'll get some of the readmits will come in with mastitis. They need some IV antibiotics. UTIs are very common. It's very hard for them to be able to, of course, we want to teach them to wipe from front to back, but it is difficult for them with the extra belly, there. So those can be a common occurrence. And if they had catheters while they were here, that can also be a consideration. Hematomas can form. A lot of times if they're sitting in one place too long, that blood will collect and they can get a hematoma in there. Thrombophlebitis, that would be IV sites, things like that. Endometritis, an infection in the endometrium, that it will require IV antibiotics as well. That is a large portion of readmits for that. And then perineal cellulitis, a lot of times the cellulitis I've seen mostly with C-sections and the incision around where that is sometimes can get cellulitis. So that's why we try to keep them in the semi-Fowler's position, just so that they're not right up on where the blood can collect and get hematomas and put stress on that C-section incision. Newborn assessment. We're looking like right after they're born, we do that APGAR score. Each item scores 0 to 2. 10 is the highest. So of course we want 8 to 10s. We do those at 1 minute and at 5 minutes. And if that 5-minute score is 6 or less, we're going to do a 10-minute score. Normal vitals for babies. Those are listed there, like heart rate is 120 to 140 beats a minute. Make sure that babies stay wrapped. They can lose heat very easily. If for some reason you take a temperature on a baby and they're cold, Remember to check a blood sugar at the same time. Those two things in infants can go hand in hand. So sometimes when their blood sugar is low, their temperature will drop as well. This is the APGAR score that we do. So you can see what that looks like. APGAR standing for appearance, pulse, grimace, activity, and respiration. Obviously, if they're blue and they don't have a pulse and they're not responding to anything, no movement, no breathing, they're going to score a 0. If there's partial things going on here, so they have acrocyanosis, which is considered a normal finding in babies, but it does take a point off that appearance score. So a lot of times you'll see baby scores like 8, 9. Usually that's due to acrocyanosis. A pulse that's less than 100 beats a minute. Sometimes some babies are born what we call stunned. And so they're not crying. They're just kind of staring. We can tell that they're breathing, but it can be irregular or weak breathing, and maybe their heart rate hasn't gotten above that 100 yet. So they're getting points taken off for those things. A lot of times that's at the 1 minute mark, and then by 5 minutes, we're usually up higher again. If we're not, then there's usually some actions being taken, obviously, by then. If baby's just moving all over the place and they're crying and their heart rate's over 100 and they don't have any blue anywhere, and they're breathing with a nice strong cry, then they're going to score full points on that. Sexually transmitted diseases. We've seen a very big rise lately in these, especially syphilis. Antibiotic treatment is the most common treatment for these things. Obviously, herpes simplex, we're not going to deliver vaginally if we have any open lesions. Making sure that these get treated during the prenatal care, so that we don't have to treat these in the hospital with the baby is our goal. We don't always get that, though. A lot of times they will be positive on admission, and so then we have to, usually babies will be admitted to NICU and observed for a while for these. And then moms are treated with IV antibiotics. Group B strep, beta strep, some people call that. That's a normal flora that's found in some women's vagina. So important factors in neonatal morbidity and mortality resulting from vertical transmission through the birth canal. Screening for this 35 to 37 weeks of gestation decreases the risk. Can be associated with poor pregnancy outcomes. Obviously, if it's untreated, it can put the neonate at risk for respiratory distress and neonatal sepsis. So usually if they are positive for this, we check all moms. If they are positive, then we treat them while they're in labor with ampicillin. They need to be treated at least 2 to 3 times for the infant to be considered not needing IV antibiotics themselves. Even if they did get treated, though, we are very mindful on assessment. So we're really looking at that, the breathing, looking for any abnormalities in vital signs with these babies, because they can go septic very fast. Chorioamnionitis, bacterial infection in the amniotic cavity. This occurs after the water's broken, so after ruptured membranes. Signs and symptoms of chorioamnionitis: maternal fever, fetal tachycardia can be one. Whenever there is sustained tachycardia on the fetal strips that you're reading, that can indicate maternal infection. Anytime if you're pressing on that uterus to check the fundus and it's very, very tender, And you can feel tension under that surface. Sometimes that can be a symptom of that as well. The amniotic fluid can have a very strong foul odor to it as well. So just noting all of that stuff and making sure that you are telling the doctor. Complications of newborns. So transient tachypnea of the newborn. Normally C-section delivery, there's fluid retention and they don't undergo the normal hormone changes. So they're unable to absorb that fluid. Preemie lungs, they're not always fully developed. We don't always have time to get those medications in. Symptoms of that, tachypnea, cyanosis, grunting, and retractions. So we're assessing those babies. Apnea of prematurity, lapse of spontaneous breathing. So for whatever reason, they appear to hold their breath. If this is lasting 20 seconds or more, making sure we're calling the doctor for that. Sometimes it's followed by what we call a DSAT. If they're on a monitor, they're being monitored continuously, you'll see those DSATs sometimes follow the apneic events. If there's any kind of color change, slowing of the heart rate, anything like that, you're notifying the physician. Always with babies, you oxygenate babies first. If you think about it, babies have been floating and breathing fluid for all of this time. And then in a matter of seconds, when they're born, all of that has to convert over to them breathing air now. So if something's going to go wrong, that's probably where it's going to go wrong first. So we always oxygenate the baby before anything else. Respiratory distress syndrome. This is probably one of the most common things. Causes for that, there's lots of different causes. It can be anywhere from trauma to the mom having an infection, anything like that. It can be prolonged hypoxemia. It's just any kind of distress in the infant. Normal breathing, respirations can be very fast. Heart rate can be slow. They can sound wet when they're breathing, so you may hear crackles, things like that. Any kind of retracting, if babies are grunting, all of that needs to be reported. Respiratory stress syndrome can go hand in hand with meconium aspiration syndrome because they inhale that meconium, they start to develop an infection. And then those first signs and symptoms are respiratory distress symptoms. Necrotizing enterocolitis, that's an acute inflammatory disease of the bowel. So somewhere there's been ischemia or limited blood supply to those cells in the lining of the bowel. Signs and symptoms for babies, poor feeding, they can be bloated, so gastric retention. Sometimes they will vomit, like green vomit. It's that bilious vomiting, and sometimes blood in the stool. That is the neonatal resuscitation algorithm. So just like we do with CPR with adults, this is basically like CPR for babies. Notice that on adults, we always go to compressions first and then oxygenation. On babies, it's the opposite. So we go to oxygen first and then we go to compressions only if the heart rate drops below 60. What I want you to look at most on this slide are the targeted preductal oxygenation requirements right after birth, because they like to throw those case study questions into tests and they can say, oh, baby at 2 minutes old is only oxygen saturation is 65%. You're thinking, oh my God, 65%. But on this chart, it shows you that 65% can be considered normal for a 2-minute-old infant. So just know that they don't reach until like 10 minutes of life do they reach the normal capacity. for oxygenation. All right, so that is the end of this. Do you guys have any questions?
No.
No.
Okay. Well, hopefully I covered everything. If you guys think of questions between now and then, feel free to email me or text me. Bonita has my phone number. She can give it to you. You guys can text me questions or whatever. Okay.
Okay, thank you.
You're welcome. Have a great night.
You too.
You too.
Bye-bye.
Bye-bye.